Welcome to our interview on gene therapy. My name is Stephanie Ping and I work at the Adult Haemophilia Treatment Centre at Fiona Stanley Hospital in Western Australia. Gene therapy has been in development for many years, and in Australia we currently have both haemophilia A and haemophilia B products in their final stages of clinical trials and progressing through the TGA process. There are many questions from our community, and today Dr. Coppens will first talk about what is gene therapy and how it works, followed by a question and answer session of all the questions you have sent through, and thank you for that. Let me first introduce Dr. Michiel Coppens, who is a haemophilia medical specialist at Amsterdam University Medical Centre in Amsterdam in the Netherlands. Dr. Coppens was trained in internal and vascular medicine at the University of Amsterdam and continued as a medical specialist in mainly thrombosis and hemostasis for over 10 years within the Amsterdam University medical community. He is the acting head of the EHA-NET and ERN EuroBloodNet Certified Haemophilia Comprehensive Care Centre. His current focus of research includes gene therapy for patients with haemophilia A and B. In 2015, which was a long time ago now, he dosed his first Dutch haemophilia patient with gene therapy and has since then dosed a total of 9 patients across different trials. He's a member of the EHAD Working Group on Gene Therapy, and he's an author of over 150 publications. Thanks very much for your time, and now I'll hand it over to Dr. Coppens.
Yeah, thank you, Dr. Ping, and thank you all for having me here. I'm here in Australia for a week, and basically to do a lot of lectures about gene therapy. And it is an interesting and relevant time right now because these therapies are really hitting our clinics and will be entering our clinics. So it's really time to get ready. In the first part of this interview, I will be doing a short presentation, basically laying out what gene therapy is and maybe tackling upfront some of the questions you may have. So I'll start sharing my screen right now and waiting a few seconds because usually there is some short delay. Yes, I see that we are sharing. Well, as I said, ask me anything. There was a call to put in questions for me here. There have been a number of questions and we'll try to address most of them. But for now, I'll just start right ahead. As always, there are disclosures. We collaborate with industry. There would be no gene therapy without the finance of industry. So there is an obvious need to collaborate, and I do so as well. However, these funds do not go into my own personal pocket. They all go to my institute. So why now? As I said, well, 22 to 24, we're seeing globally the first regulatory approvals of AAV gene therapies for both hemophilia A and B. And Dr. Ping already mentioned where it started for me. It was already back in 2014 when the preparatory work started. And actually it started with Amsterdam Molecular Therapeutics, which was a spin-off company of my hospital, which later became Unicure, and that's the company that developed etranacogene desoparvovec that became Hemgenix, and that's the provisionally approved hemophilia B gene therapy now in Australia. And I'm here, as Dr. Ping said, because have some experience there. I've dosed 9 patients in Hem A and Hem B in different trials. And what you see here on the right, of course, in Dutch, was a bit opportunistic, but in January 2016, we were proud and happy to be able to report that we were the first center that actually dosed a patient with hemophilia B gene therapy in the Netherlands. So I'm going to start with some basics. For some, this will already known, for others probably not. So I'll work through the basics of proteins and gene therapy. Essentially, the clotting factors, clotting factor 8 and 9, are proteins. And proteins are essentially long chains of amino acids built into peptides, but this chain is then folded into complex 3-dimensional structures, and that's actually the protein. So, and the code for proteins are genes. Essentially, the genes are or contain the codes for the specific sequence of those amino acids in proteins, and all of those genes are located on the human chromosomes. And as you can see in the picture below, there are a huge number of chromosomes, but the genes for clotting factor 8 and clotting factor 9 are on the so-called X chromosome, which makes severe forms of hemophilia predominantly a male disease. Essentially, the liver is responsible for the production of most of the proteins in the human body. On the left-hand side, you see a human cell, and essentially most of human cells have exactly the same machinery that is able to produce proteins. The liver does the bulk of the human protein production, but essentially most cells have those machinery in place. So essentially, gene therapy is about to feed this cell protein manufacturing machinery, the protein factories, feed them the right code of the missing gene, and then that cell is able to generate that missing protein. That's the basis of gene therapy. However, the big problem is, how do you get that DNA, that missing DNA, into cells? Because most things you will do to cells will actually destroy the cells, and they will not be able to produce protein. Well, that's where where nature comes in. There's a specific organism that is able to enter cells smoothly, and those are viruses. Viruses, we all know, and you see them on the left-hand side. So essentially, gene therapy is about using the outside of a virus that is enabling to get into the cell, and then the inside of the virus is actually replaced by the gene of the missing protein, factor 8 or factor 9. And here you see how that looks like. The AAV capsid. The capsid is the outside of the virus, which enables it to pass into the human cell, with a gene cassette, that's the DNA of the missing gene, and those combined is what we call AAV gene therapy. AAV, what is that? That is an adeno-associated virus. That's a specific type of virus that is generally used in most gene therapies and in all hemophilia gene therapies. Why are we using AAV viruses? There are some very important aspects. What you see on the left-hand side is that the DNA that is entered into the human cell by an AAV virus is placed so-called episomally. It's essentially non-integrating. Integrating would mean that the gene is actually put into one of those chromosomes, the big sort of X thing you see, and would be inserted in there. And that actually contains a certain risk, and that's what I call fatal integration. What if that gene would be placed right in the middle of another gene that is actually quite important to the human body? Or maybe what we call a tumor suppressor gene. If that gene is wrecked because something is put in there, that may lead to what we call fatal integration. And that's always a sort of a risk thing. And that's the most important thing why we're using AAV, is that it's largely non-integrating. The other benefit is that it's hardly immunogenic. Natural variants of AAV may cause a cold, but just as likely you will not experience any symptoms at all. However, there may be some downsides because of this episomal localization of the DNA. When a cell divides into proliferates and becomes two offspring daughter cells, the DNA that is placed episomally may actually not be transferred to all the daughter cells. So that means if you have episomal DNA, it may be lost over time inherently. And essentially, 10 years ago, when I started the gene therapy, that was my primary assumption, that episomal DNA will be lost in due course of time. The other downside is that you may have been in contact with the natural variant of that AAV virus that may or may not have given you slight flu symptoms. But as a consequence, that will mean that you have antibodies to that virus. And if you have already antibodies against the natural variant of the AAV, The fear is that it may not work when you use this gene therapy because it's essentially already being broken down by your immune system before it's able to affect your liver cell. So what's the current status in Australia? On the right side, you see the first gene therapy for hemophilia B, etranacogene dezaparvovec. The brand name would be Hemgenix, and that's the one where there is now provisional approval for in Australia. And on the left-hand side, you see the first gene therapy for hemophilia A, already approved in Europe and in North America, and that's called valoctocogene roxaparvovec Roctavian. That is, they have filed for approval in Australia, and it is currently under review. So starting with the results, the hemophilia B etranacogene dezaparvovec trial included 54 patients in total, and they got a single infusion of 1,000 billion genocopies, gene therapy particles infused in a single infusion over 1 hour. So what happens then? Those virus particles infect the liver cells and donate the missing DNA to the cell nucleus, and the liver starts producing protein. Here you see the hemophilia B trial, and what you actually see is that the factor IX activity goes up to an average of 40%. These were all patients that started with a factor IX activity of 2% or lower, and on average they moved to 40%. However, what you also see is error bars. Those are the bars coming out of those bluish boxes. That means there's also considerable spread. Some people end up slightly lower, more or less 10% or lower, and some people end up in the really higher end. And at this point, we're not really sure what determines what level you will be reaching. So that's always sort of a question mark. How high will you go? But on average, we see 40%. The most important thing to appreciate from this slide, because this is a 3-year follow-up, is the apparent stability of the factor IX expression achieved here. People get up to their factor IX activity actually somewhere between week 4 and month 6, and that's probably more near the week 4 than near the month 6, and then it remains almost completely stable thus far throughout the complete follow-up. The farthest follow-up thus far there has been for 3 years. So then moving from Hem B to hemophilia A, there's a slightly different picture. First, I talked to you about the error bars, what you're seeing here, and now you're also seeing error bars here, but they are considerably smaller. But that's sort of a misrepresentation, because these are slightly different error bars, and the variability of the expression is actually significantly larger than in the hemophilia B. The range of factor VIII levels you may end up with is quite high, varying from almost 5% to well over 100%. The average, though, average is around 50%. However, what you can also clearly see, and that's the contrasting picture with hemophilia B, is that there's a peak effect, and that peak effect is around the 6-month mark, and then it seems to be going down. And the big discussion thus far is this going down, and will at some point it end, leading to a full loss of expression, or does there remain a proportion of patients who will have sort of a sustained, stable level over time? And essentially, this is the 4-year follow-up there is been thus far. It's been quite recently presented at a summit in North America. And this is the numbers you're seeing. 4 years, there is still 16% on average factor VIII activity there. So what does that mean for a patient if your factor VIII or factor IX activity goes up? Well, the simple point and the primary goal, I think, for gene therapy is that almost all patients can stop prophylaxis. However, you should also be aware that it's just not a cure. Most patients will not end up in a normal factor VIII or IX range. They will end up in a milder hemophilia range, but that still means that they have a milder form of hemophilia. So patients will need additional factor 8 or factor 9 when they undergo surgery or when they have a serious trauma. What we've also seen that people in these gene therapy trials have less bleeding and significantly less bleeding, about 60 to 70% reduction in bleeding. And that's even compared to regular intravenous factor prophylaxis. And especially when your factor activity is somewhat in the higher ranges, that may give you also more leniency to high-risk activities without having to worry too much about getting a bleed. There's something new that's been coined by several colleagues of mine in Europe, and that's something that's called the haemophilia-free mindset. And to some extent, that's an interesting concept, but there's a sense of, we have seen anecdotal stories of patients who have, well, changed, more or less changed, having to think about the disease, it's getting their disease getting to the background more or less, and having a free, well, hemophilia-free mindset. And I think there's wonderful anecdotal stories of patients who have experienced that. However, at the same time, we should also realize that not all patients get into the real high end. So the primary goal is to get rid of the prophylaxis and hopefully get high enough to be able to sustain some form of damage or some form of trauma. However, when we talk about a once irreversible therapy, it's just as important to focus on what we don't know yet. And there is stuff that we don't simply know yet. And that's what I want to talk you through. The big and first question, the number one question that tops all of them is simply, how long does it work? I've just shown you on the left-hand side that in hemophilia A, there is a peak in the factor 8 activity about 6 months and a decline thereafter. And the big question still is, does it level out at some point to a lower factor activity, or will it wear off at some point and will all expression be lost? How long will that take? Well, it's hard to say. 3 to 5 years, maybe, I don't know, maybe longer. And for some patients, we have seen in the trials also sometimes shorter. If we flip the perspective and look at year 3, of follow-up in the studies, we've seen in the hemophilia A study that 13% of patients had to go back on prophylaxis because of progressive loss of expression. On the other side, hemophilia B, as I said just now, it looks quite stable. But what does that mean? How long will it last? Well, we need to realize that this registration study, the maximum published follow-up has only been 3 years. So we don't know for the most patients much more experience than the 3 years. However, before you get to a registration study, there's always a phase 1 study, as we call it. Less people, 10 in total, but that started quite a while back. And for those patients, we now have a follow-up of 5 to 7 years. So that's, and also in that study, 5 to 7 years, quite stable expression over that full period of time. And there's one, and I think that's the landmark, the front runner study in hemophilia B, that was from the UK, University Colleges London, and they now have over 10 years of follow-up. And similarly, as in the other hemophilia B trial, we've seen a very stable expression of factor 9 there. So there is hope that it will get you expression more than 10 years. And some optimists, and I wouldn't dare go as far, but some optimists say that it even may be persistent and ongoing. If we also here flip the perspective and look at year 3, at year 3, there has been now one patient who has had to go back on prophylaxis in the hemophilia B trial, and that's 2% of the trial population. The other point is a rise in liver enzymes, and that liver enzyme is generally called ALT. That's the most common side effect of gene therapy. And typically this occurs within the first 12 weeks after the gene therapy administration. In the very, very, very early phase studies on gene therapy, there was quite a clear case where it was shown that this ALT increase was caused by an immune reaction specifically directed at the liver cells containing the gene therapy. So in fact, your immune system would recognize the cells that have had gene therapy and specifically attack those cells. And if that happens, that can lead to a loss of the factor 8 or factor 9 activity. And again, in that front runner study in the UK, they decided to really monitor the ALT levels. And as soon as they got up, people were treated with the immunosuppressant prednisolone. And actually that worked. And simply because it worked, it became the norm for all the gene therapy trials thereafter. Again, we're seeing differences between HEM-A and HEM-B. On the left-hand side in the hemophilia A trial, we've seen that around 80% of participants, of recipients of hemophilia A gene therapy developed ALT rise and had to go on corticosteroids. The good side is that maybe due to that prednisone, there was no further loss of factor 8 activity with that ALT increase. However, there is a price to pay because the average duration of prednisone therapy was 6 months. And that's an average. There were people, the shortest period was 3 weeks, but the longest period was well over a year, 18 months. So that's quite a long time. And prednisolone may be a therapy that will give you side effects. Most people will notice when they are on prednisone. So there is a price to pay. In the hemophilia B, also some people develop ALT, but the prevalence is much lower, and it was 1 in 5 patients had ALT increase and had to go on prednisone. Again, also there, the prednisolone at least seemed to prevent any loss of factor 9 activity, and the total duration was still quite long, but shorter than in the hemophilia A, 3 months with a spread of 1 to 4 months. The other thing I talked about you already in the introduction is that you may have been in contact with the natural variant of that AAV virus. And that's what I call pre-existing immunity against AAV, because in response to that infection, you will have developed antibodies against that particular virus. What we know from surveys is that approximately we should expect 25 to 35% of people to have been in contact with that AAV virus and to have antibodies. And generally, it's always been presumed that if you give a patient gene therapy, before that gene therapy is able to successfully infect the liver and donate the factor 8 or 9 DNA, it would already be eliminated by your immune system. However, there was a sort of a lucky error in the hemophilia B study. In the first phase study, during the study, the first 10 patients, they actually switched an assay, and it turned out that in hindsight, 3 of patients that they were dosed already had AAV antibodies, and to their surprise, they expressed factor 9 as well as those without antibodies. And now it has been fairly well established that in this hemophilia B study, it works as well in patients with low titer antibodies as in patients without antibodies. They are tested as a screening part, but it's not an exclusion criterion for hemophilia B. In hemophilia A, similarly, we should expect 25 to 35% of patients having these antibodies. And in the hemophilia A study, at this point, if you have pre-existing neutralizing antibodies, you are ineligible. So if that titer comes back positive, you cannot get this gene therapy. Similarly, there are now studies ongoing for patients with hemophilia A that have antibodies to see if, like in hemophilia B, those antibodies would not be problematic. But until there is positive evidence that you can actually dose those patients, you are completely ineligible if you have neutralizing antibodies in HEM-A. So long-term effects, if we're doing a once irreversible therapy, what about the long term? You really have to wait long to see long-term effects. I told you the biggest benefit of the AAV is that it's a so-called non-integrational localization of the DNA. However, that's not fully true. Non-integrational means that less than 0.5% integration occurs. But if you are treated with 1,000 billion genocopies of gene therapy, some integration will occur. And there's always been a theoretical risk of that fatal integration and whether or not that could lead to liver cell cancer. Excuse me for the typo here. And in fact, in the hemophilia B study, 1 year after gene therapy, one person actually developed liver cancer. And I have to say, that was a person from my own center. That was a patient I have, that was under my care in this trial. And immediately we were aware that we needed to get to the bottom of this, whether or not this was caused by gene therapy. Because if it were caused by that gene therapy, that could mean the very end of gene therapy for hemophilia altogether. So in collaboration with a laboratory in Germany and the sponsor of the study, we did an extensive integration analysis, and we were able to conclude that this was not a complication of gene therapy, but actually we found a few mutations that were quite typical for patients who have had a chronic hepatitis C in the past and could and develop liver cell cancer as a consequence of a chronic hepatitis C infection. But a very important one. But as a consequence of this event, there is this ongoing cautious approach that everyone who receives gene therapy gets a liver ultrasound twice yearly to monitor for any such effect. So moving into practicality. Before gene therapy, there needs to be some screening. As I told you, the AAV antibodies need to be tested. And if you have any for hemophilia A, that's where the story ends. For hemophilia B, depending on the titer, you can probably go ahead. The other thing that really needs to be monitored is to assess chronic liver damage. Some patients may have had prior hepatitis C, which has been pretty common in the hemophilia community. But now, emerging pandemic is what we call fatty liver disease. It's now the #1 cause of liver transplants globally. So that's an emerging disease, and patients who already have significant liver damage are ineligible for gene therapy. So that means you will need to go undergo some testing, blood works on the one end, and some form of imaging of the liver to make sure that there is no chronic liver damage. The dosing day. Well, the dosing day really is a big day to some extent. You know, this is on the left-hand side, you see Dan Brederveld. He's a patient with hemophilia B. He was treated in the context of the hemophilia B trial. And I'm showing this picture with his permission. He's an occupational health physician himself. And this is the typical picture every hemophilia gene therapy recipient has, being there on the bed. And this is me getting an infusion into his arm. I say that's a big day because the first patient I dosed, that was already 9 years ago. I bring him each year to teach medical students, and he always remembers the particular day on which he received gene therapy as much as he remembers the day of his marriage. So this is a very instrumental, big day in a person's life. From a doctor's perspective, and maybe also from a patient perspective, it's not that big a day at all. You come into the hospital, you get an infusion, which is usually uneventful. That infusion takes about 1 hour. However, you are longer in hospital than 1 hour. We actually do not let the pharmacy prepare the gene therapy until you are actually there. What if you trip before entering the hospital and cannot receive gene therapy with a product that's hugely expensive? We just don't want to run that risk. So people come in a few hours early. And also in protocol, as I've heard in Australia, that they are panning out. That means afterward, observationally, you will probably have an overnight stay at your center just to be able to, if anything occurs, that you're in a place where you can get, well, immediate response, evaluation, etc. So approximately 10 to 15% of patients will experience mild infusion reactions. That may be feverish, that may be chills, that may be discomfort. Those are usually pretty mild. Sometimes the infusion can be interrupted, but then resumed later at a slower pace. but most of the patients with these matters can sustain the infusion quite normally. In the first 24 hours or so, some people experience some form of flu-like symptoms, 10 to 15%. And personally, I think that may be a consequence of a sort of a mini AAV sort of infection. I had one patient who told me, I asked him the next day, how did you feel? Yeah, well, I felt fine. Yeah, well, it was a bit chilly when going to bed, so I just tucked in better in bed, and then I felt fine afterwards, and I feel fine today. But those kind of flu-like, very mild symptoms may also occur. What I'm showing in the red, and there are different plans already being prepared and laid out by Australian Haemophilia Treatment Centers, and it actually may be that you will not, if you will be receiving gene therapy, it may not be in your own center. There are probably going to be centers that will be dosing centers. That has to do with all the environmental permits you have to be able to do gene therapy, but the dosing day may actually not be in your own hemophilia treatment center. Thereafter, all the follow-up usually should be in your hemophilia treatment center. The follow-up is quite important. There's a short-term follow-up, and this is probably one of the most important things to remember. You need to undergo weekly blood sampling for the first 3 to 6 months. Why? Because we really want to see in time if you have an ALT increase. Because if that ALT increase is caused by an immune response that leads to the loss of gene therapy, you need to go on prednisone. And that's something that you need to plan in as one of the possibilities when you're choosing for gene therapy. If you need weekly visits for 12 to 26 weeks, even that can interfere with your holiday planning. And most of the patients, I said, basically, so you probably can't go on a holiday unless it's really close by. The other thing is condom usage. While there is basically, the gene therapy does not go into your sperm cells, there is some shedding of the viral, the viral capsid, the outside of that virus, that will end up in your blood, that will end up in your nose, and also in your semen. And as a precautionary measure, the label says that you should use barrier contraception in the first year after gene therapy. So basically, if you're really planning on children, not in the first year after gene therapy. Alcohol, well, basically, you need to be cautious with alcohol. Of course, I don't think it's realistic to say that you can never drink alcohol to keep your liver in the best condition possible. But maybe in those first 12 to 26 weeks, you want to be really careful. What if a good night of alcohol would lead to a slight ALT increase on the next day of blood sampling? That will mean that alcohol will put you on prednisone. And that prednisone can be 3 to 6 months. So really be careful with alcohol, especially in that short-term period. Once you're through that phase, you go into the long stage follow-up and blood sampling usually every 3 months. As I just told, twice yearly, you will get a liver ultrasound. And essentially, I think that's probably the way it works. I think we're going to want to follow up patients for long-term and maybe even for long-term for the rest of your life. And one of the challenges, I guess, is again logistics. What if you don't live near your hemophilia treatment center? Or if your hemophilia treatment center is not yet experienced within gene therapy? There's specific demands on logistics, on where do you get your blood samples drawn, how do you get those results to your hemophilia treatment center? The Australian centers are already quite far in thinking about how to manage that. But again, there are some logistics on how that should be. So positioning of gene therapy, where will it be? Will it be a therapy? No, of course not. I think this is probably what we should be choosing. Clotting factors intravenously, they have proven efficacy, proven safety over the years, and a lot of people will stay there. Non-factor replacement for hemophilia A is really, well, gaining popularity over the last recent years, and is already a new therapy with less treatment burden than frequent IV injections. So I guess as a thorough competitor of any therapy. Other new therapies also emerging. And finally, there is gene therapy. And ultimately, I think about gene therapy, probably if you look at the in and exclusion criteria, the eligibility criteria, if we disregard the neutralizing antibodies as we can in hemophilia B, I think probably most patients will be suitable for gene therapy. But then again, I don't think everyone will choose for them. Probably it has to do with who you are. So that's something you really need to think about. You always have the persons that pre-order the next iPhone way before it comes. Maybe those are the ones who have entered trials. But there's also a group of people just want to sit at the back of the bus and only wants to step in as long as it's really, really proven. So I think much of this is about how do you feel. So essentially, what you need to think about is about different scenarios. What you should realize that this is a sort of an irreversible treatment. Once you've done it, once you've had it, you can't go back. The big upside, of course, would be no more prophy, at least for a while, and hopefully for a very long while. You can expect a better bleed protection than you have had with your regular factor prophylaxis. But you need to balance that with potential downsides. There is an intense follow-up that you probably will need to adhere to. There is a chance that you will need to go on prednisolone. Are you willing to do that? Lifestyle, as I just told you, alcohol, especially in those first weeks, and barrier contraception for the first year. And ultimately, that's at the bottom right, there are inherent uncertainties about durability, and always with new therapy, unexpected long-term effects. So essentially what it comes down to is that you need to make a trade-off to the benefits you hope to achieve and how much of uncertainty you are willing to accept to get those benefits. And I think, yeah, actually, that was my last slide, so I'll stop sharing there and let's open the discussion with Dr. Ping.
Thank you very much, Dr. Coppens. That was a brilliant presentation and I think very clear for the patient community. I think you really, really nailed the kind of practicalities of it and the benefits and the risks of it. You were sort of touching on kind of the durability. Some of the questions that came out from the community were including really, what about the existing damage to my joints? Will it improve that? Will it decrease it? Does it affect it? That kind of stuff.
I think realistically, joint damage, hemophilia arthropathy, as we medically call it, is irreversible joint damage. So essentially, you shouldn't expect your joints to heal when your factor VIII level goes up or down. So essentially, that's part of the discussion, right? If the patients who are going to get gene therapy, ideally, you want to get the gene therapy to them before they have already existing joint damage. So I'm afraid that the joint damage really will persist.
And I mean, this is sort of more of a theoretical question now, but do you ever envisage gene therapy in a pediatric population?
Well, realistically, I think that's the ultimate goal. That would be but that's still painting a far picture, a real far distant future. There's something. The hard part about children is that they have growing livers, and growing livers means those livers proliferate. And in a proliferating liver, I'm not 100% sure that this AAV gene therapy will actually persist in a growing liver. So probably that will take another form of gene therapy, maybe an integrating form of gene therapy, but that needs to be safe above everything else. So yes, that's definitely the long-term goal, but I think that we are years to maybe even decades away from gene therapy in children.
Okay, interesting. So the other question that came along from the community was, I guess they were concerned about whether or not they can have children after gene therapy, and does the gene therapy actually affect the kind of inheritance of hemophilia?
Yeah, it's an important question, comes up a lot. Essentially, the gene therapy doesn't do anything with your sperm cells. it really goes into the liver. So it means that in your sperm cells still have or still don't have the correct hemophilia gene. So essentially, your offspring will not be cured of hemophilia because you have had gene therapy. They will still have the same inheritance of hemophilia as usual. As I also just told you, there is a reason to use barrier contraception for the first year. That's not because we think that there is a real risk of your children within that year getting something, but that's really a very precautionary measure. And after that year, yeah, you can have children, and there have been children from patients who have undergone gene therapy in the past.
And then, so you were kind of outlining the benefits of it, and you were talking about decreased bleeding risks or decreased bleeding events, and a sort of surrogate marker of factor levels. What about if they needed major surgery, for example, like they needed their appendix out or gallbladder out at some stage? What happens then?
Well, I guess it depends on what factor activities actually achieve. If you happen to be a patient who ends up, let's say, 70 or 80% factor 8 or factor 9, then probably you are good to go for most types of surgery. But realistically, the transformation is to a milder form of hemophilia, and it's not a cure. So realistically, you have a milder form of hemophilia, so you need additional factor 8 or factor 9 to safely undergo procedure.
And would it affect, for example, the risk of developing inhibitors later on?
I don't think so. Please note that in the studies that have been done, they were quite selective and only including those patients who have really been experienced factor 8 or factor 9 users. We know that if you have had more than 150 days of factor 8 or factor 9 infusion, the chance that you will ever develop an inhibitor will be really small. So generally, I don't think there is a big risk of any inhibitor development. Thus far, in all the clinical trials, there has not been a single patient who had an inhibitor development, as far as I know, that has been in congresses and publications.
Okay. All right. And you were talking about the sort of side effects and the use of steroids. Have you, separate from that, have you noticed any sort of unusual impacts on patients who you've given gene therapy to in terms of their mental health and their overall kind of image of themselves?
Yeah, well, generally it is really a positive picture because most of the patients really move out of the severe hemophilia range to a much milder range, and they will have a much less severe disease. So actually, some of those stories are really powerful and beautiful anecdotes how it changed their lives. So generally, these are positive. But again, especially in HEM-A, but there will be patients who have had success, who have been off prophy, that will need to go back on prophy. That will do something to you mentally. So that can be a huge blow. Similarly, if you go into the screening process and you're really set on getting this gene therapy, and then you are someone with neutralizing antibodies or have some pre-existing liver damage, that's a huge mental blow. That's some of the things you can see. But for those successful, I think, well, more and more patients are now coming also to conferences and listening to those anecdotes. And I've even had some of my patients come to conferences. Those are really beautiful stories and generally very positive.
Have you ever had a situation where siblings, one has and one hasn't been successful? Has it changed the family dynamics?
I can imagine so. I don't have any particular examples, but yeah, sure, I could imagine, yeah.
Okay, just moving very on to a few other questions that have come from the community. I guess somebody asked whether or not gene therapy would be suitable for patients with mild haemophilia.
Essentially, technically, it's possible, and yeah, if you're moderate or mild, but in a lower mildest range, I think there may be benefits for gene therapy, but ultimately, I don't think regulators will let it get that far. the stupid thing is that you need to realize that this is very expensive therapy. And essentially that means that that will probably be licensed for patients with severe forms of hemophilia that already need to use factor concentrates for prophylaxis, and prophylaxis costs a lot. So there's an interesting financial trade-off to be made. And personally, I'm afraid I don't see it coming for patients with mild hemophilia, and probably of a cost issue.
Okay, thank you. I guess realistically as well, the gene therapy, sometimes maybe the mild hemophiliacs have actually higher levels in a way than what has been seen in the gene therapy trials, hasn't it? You know?
Yeah, well, the stupid part is that even if these new therapies are getting very successful, then maybe the moderate hemophilia or the mild hemophilia with the lower ranges may become the more severe patients.
Yeah.
However, if you are a mild hemophilia patient, and let's say you are 15% or over, in general, you shouldn't have too much bleeding on an annual basis. So adding, let's say 10, 20, maybe 30% will not create a huge dramatic shift in the number of bleeds you will get on an annual basis. The difference is just bigger coming from severe hemophilia moving to mild than from mild to less mild.
Yeah, yeah. Just shifting gears slightly, I guess one of the major unmet needs in our community are patients with type 3 von Willebrand disease, and they, as you know, have very low or no factor 8. Would this type of gene therapy be applicable to them, or can you envisage something else?
Gene therapy, this gene therapy essentially not, because basically patients with type 3 von Willebrand disease have a perfectly normal factor 8 or 9 gene. So there's no point of it producing another factor 8 or 9 DNA into their cells. So the therapy will need to come from something different, and probably will need to come from Willebrand itself. Von Willebrand is a very big molecule, multimerization, complex molecule. So putting that into gene therapy is more challenging than for hemophilia. There are, well, initiatives, preclinical only, ongoing to also try to work gene therapy for von Willebrand's disease. But as I said, significant challenges. And thus far, the most effective form of prophylaxis will be tackling von Willebrand itself, but that still requires at this point frequent von Willebrand factor infusions.
Okay. All right. Thank you very much for your time, Dr. Coppens. I think that's most of the questions covered. I will end it here. Thank you.
Well, thank you very much, and it was my pleasure of trying to help out the Australian community.
Brilliant. Thanks.